Okay, so where were we? I don't know. Sometime there is a connection problem. It's not about Zoom meeting duration. It's only about connection problem. Sometime it's happened. Okay, so we were discussing that if there is a idiopathic generalized epilepsy, the risk of having seizure free is 74%. So focal epilepsies, they are more having the chance that the patient have seizures during the pregnancy. So this is something different because we until now we know that generalized tonic-clonic seizures they are high risk for having SUDEP. But having the seizures during the pregnancy, the focal type of epilepsy, they have more chance to have seizures during the pregnancy. Okay. So there is insufficient evidence to assess whether the rates of status epilepticus are increased in pregnant women. We don't know. So if they will ask you this statement, the risk of a status epilepticus increase during pregnancy, the answer is false. We don't know. Insufficient evidence. We cannot say that. And what is the definition of status epilepticus? The definition is it is defined as 30 minutes of continual seizure activity or a cluster of seizures without recovery. So 30 minutes the patient will have seizures or patient will have clusters of seizures, one seizure, another seizure, third seizure, so it will not stop. So there is no test to predict the risk of seizures deterioration in the pregnancy. So we cannot predict which patient will have this seizures. So how should risk be communicated to the woman with epilepsy? We have to give the written and the verbal information, especially on the prenatal screening and implication, and also have to tell the patient that she should not self-discontinue the anti-epileptic drugs because this is the most common cause of uncontrolled epilepsy during the pregnancy, that they are stopping the drugs and the effect of seizures and epileptic drugs on the fetus, and you have to counsel all those things including the breastfeeding and contraception. So it is like your OSCE station, what you have to do all these things. So women with epilepsy should be informed that the introduction of a few safety precautions decrease the risk of accident and minimize anxiety. So this is something related to counseling. And also they have to be aware that future pregnancy, what will be the implication of future pregnancy on their epilepsy, sorry, and what will be the effect of health for their offspring, the short and long term. Okay, so any information on prenatal screening should highlight the detection rate, limitation of the test performance, and the implications such as termination of the pregnancy. Okay, so especially women, they are overestimating the risk, and the risk perception for the woman is very important when you are counseling the patient about that the risk is high or low, because they are overestimating the risk when they are taking anti-epileptic drugs, or maybe they don't want to take it. This is very important in the counseling. Antepartum management, what you will do, what are the recommendation models for antenatal care of women with epilepsy, and what are the benefit of joint obstetrics and neurology clinics. So they mention about two types of team. First of all, the woman should have regular planned antenatal care with designated epilepsy care team. And then if the woman become unexpectedly pregnant, if she has to discuss the therapy with the epilepsy specialist on an urgent basis. So it is never recommended to stop or change anti-epileptic drugs abruptly without an informed discussion. So yesterday I was seeing, uh, I think one recall was there, and they were asking the patient is become pregnant, and she was taking sodium valproate, and there was another drug, I think lamotrigine or phenytoin, I don't remember. But
Yes,
they said
pethidine.
she become pregnant, and now what you will do? So the answer was urgent review of medication, and who will do this review? This epileptic specialist or whoever the person concerned should review urgently this patient. So if there is a choice that stop the medication immediately, so you will not select that option, you will select urgent review of the medication. All pregnant women should be provided with information about the UK epilepsy and pregnancy register, invited to register. They have special register, so any patient with epilepsy and pregnancy, you will counsel her to get herself registered for future research and further national consensus. The multidisciplinary setting, now which type of multidisciplinary team? There will be a obstetrician who have special interest in epilepsy, or there will be a neurologist with a specialist training in epilepsy, or there will be a epilepsy specialist nurse. So the either neurologist or either a epilepsy specialist nurse. And sometime we need neuropsychiatrist also, and also sometime you can involve the midwife also. So if this model is not available, at least you need obstetric physician or bio-obstetrician with training in the maternal medicine with input from the midwife and neurology team can also contribute to improve continuity of care. So the team should be the obstetrician, who have either maternal medicine expert, obstetrician with maternal medicine training subspecialty, or an obstetrician who have special interest in epilepsy. Okay, and then they can say either obstetric physician, an internal medicine person, or who have special training in with the epilepsy, or the good one is neurologist if he have special training in epilepsy, or it can be epilepsy nurse or a midwife. These are the multidisciplinary team. So we already know the drug should not be stopped abruptly or changed without appropriate decision. Even high-risk drug sodium valproate, these are still the drug of choice for certain epilepsies. So we have seen the patient who are taking the sodium valproate when they are coming to us in the pregnancy. So we should not stop the drugs, and some conditions still need these drugs. So, what is the optimal method and timing of screening for detection of fetal abnormalities? We will do structural abnormalities detection at anomaly scan of 18 to 20 weeks and 6 days for major identification, cardiac defects, and the neural tube defects. And they said we will offer routine, the one who is recommended for routine screening and biochemical screening, because the first trimester screening alpha fetoprotein with ultrasound, so you can detect the neural tube defect 94 to 100%. So we can offer these women, but routine fetal echocardiography in detecting congenital heart disease in baby with women with epilepsy taking anti-epileptic drugs compared with the 20-week detail scan, it is currently offered. So there is no routine offer of fetal echocardiography. We are not offering routine fetal echocardiography. I remember for another, for example, if the diabetic woman or there are other risk factor or previous congenital heart disease risk, we are offering them fetal echocardiography at 24 weeks. Those women who have previous baby with cardiac disease, but they are saying here if the patient is taking epileptic drugs, and for only for this reason you will not offer routinely unless they have another risk factor routinely fetal echocardiography. So how should women taking anti-epileptic drugs be monitored to avoid worsening of seizure? For women taking with epilepsy taking anti-epileptic drugs, is dose escalation better than expected management? Okay, so there is a current evidence that routine monitoring of serum anti-epileptic drugs is not recommended, but individually you can take the decision individually. What will happen? Most anti-epileptic drugs, their levels falls during the pregnancy because of different pharmacokinetics. Even lamotrigine, it will falls up to 70% in the pregnancy because of hemodilution and other pharmacokinetics. So they said because of this falling drug level, maybe it will lead to worsening of the seizure, and you need to prophylactically increase lamotrigine. Some have postulated this one, but other clinician maybe say that maybe you will increase the dose and maybe you will increase the dose related risk. So there is still no conclusion until now. So current practice is that either regular therapeutic drug monitoring or you will monitoring based on clinical features. Either you will do monitor the patient whether she has fits or she's fits free, then accordingly you will adjust the dose, or in worst cases then you will do the anti-epileptic drug monitoring. So there is a no one rule. Okay, accordingly you will decide. So also they said if you will monitor the therapeutic drug monitoring, it doesn't tell that the seizure deterioration will be decreased. So this is individual decision. What are the adverse effects of anti-epileptic drug in pregnancy on the mother, and how can they be minimized? So what are the effects? First of all, any patient with epilepsy, they can be showing sign of depression, anxiety, and any neuropsychiatric symptoms, because not only because of the drug side effect. So you need to offer them refer to perinatal mental health team, because if they you have any concern related to cognitive function such as attention and memory in combination with mood disturbance, if they have mood disturbances in the scenario, if they will give, the patient is taking anti-epileptic drug, and now she came to you, the husband is giving history that the patient have mood disturbances, or she has loss of memory or attention problem. So think about the side effect of anti-epileptic drugs. So in this case, maybe you want to send the patient to perinatal mental health team. In the EMQ, maybe you want to select that option. So, clinician caring for mother with epilepsy taking anti-epileptic drugs should be aware of the effect of the drug, particularly those related to cognitive and psychiatric problems. So, there are some drug side effects of those drugs that it can lead to cognitive and psychiatric problem. So, what you will advise the woman that some drugs, some particular drug, they can cause depression, and because of that, they can have low mood, inability to plan and organize thought, poor concentration, tiredness, irritability, or anger. So she has to monitor these symptoms, and she has to come back to us, and she because early intervention may improve the quality of life. So this is the part of the counseling, the risk of the side effect of the anti-epileptic drug. In addition to teratogenicity, there is some mood changes, there is cognitive problems, and there is different depression or anxiety also. So we sometimes they might need to be referred to the perinatal mental health team. So, what are the risks of obstetric complication in pregnant women with epilepsy, including those taking anti-epileptic drugs? So, what are the obstetric complications? Obstetric complications, they talk about there is a if the woman is taking anti-epileptic drugs, maybe high risk of induction of labor, maybe because they are more risk for having IUGR, okay, and maybe they have postpartum hemorrhage. So I will discuss because I make another slide for this one. So there is a review who examined the pregnancy and reproductive outcome in relation to epilepsy in the pregnancy, and they said the odds if women with epilepsy compared with women without epilepsy, the odds of spontaneous miscarriage, antepartum hemorrhage, hypertensive disorder, induction of labor, cesarean section, and preterm delivery, fetal growth restriction, and postpartum hemorrhage. It all increases. So sometimes they are giving you in SBA 5 option, or and then you have to exclude one. So all of these increases risk if the women have epilepsy, more chances of miscarriage or antepartum hemorrhage or a high blood pressure, induction of labor, cesarean or preterm because they might have a chances of IUGR, or because of fits, maybe you want to deliver the patient, so risk of iatrogenic preterm delivery and the postpartum hemorrhage. But if you will see the gestational diabetes or perinatal death, there is no difference. So gestational diabetes or perinatal death, there is no difference, but hypertension and IUGR or APH or PPH, there is a high risk. So don't forget diabetes or perinatal death, the risk is same. Okay, so how should women with epilepsy be monitored in the pregnancy? First of all, after booking appointment, every visit you have to see patient well-being, that she's ability to cope, her memory, concentration, sleep, any generalized condition. You will ask tiredness, dizziness. Also, she's taking drug regularly, the doses, and if she has fits, how much frequency, what type of fits, there is aura or no aura, and if she need admission, you women with epilepsy at reasonable risk of seizure should be recommended in an environment, because these type of patient they should be observed closely, because the risk of having SUDEP is higher in this condition. And also you need to discuss early with epilepsy specialist nurse or neurologist if there is a deterioration in the seizure control. Also, the precipitating factors, they talk about fasting, sleep deprivation, stress. You have to identify and manage accordingly. Also need a specialist advice, want to change the drug dose, or you want to add the drug or admission, you need specialist advice. And also active seizures, advising on care to minimize the period of time they go unobserved should be considered. Individual with unwitnessed seizures at high risk of SUDEP, with nocturnal seizures being an independent risk factor. So, majority of women, you will find in the morning that they are dead because they have mostly seizures at night and they were alone, so nobody was there. So this is an independent risk factor, nocturnal seizures. So that's mean these women should not sleep alone at night. Also, in patient nursing, the environment should be that the patient can be monitored closely. So, how should the fetus be monitored in the pregnancy? What are the effects of anti-epileptic drug on CTG? So, what are the effects? First of all, serial growth scans are required because they have risk of SGA if the woman is exposed to anti-epileptic drugs. And there is no routine antepartum fetal surveillance with CTG if the patient is taking anti-epileptic drugs. Routinely, we are not doing like, okay, this patient is anti-epileptic drugs she's taking, so now every week you do twice weekly CTG. No, there is no rule. And also, they said the odds are 3.5 times higher in women with epilepsy exposed to anti epileptic drugs compared with those not taking anti epileptic drugs. The odds of having IUGR baby. This I wrote here. The odds of having IUGR baby, if the woman is taking drugs, it's 3.5 higher. So if the woman is taking anti-epileptic drugs, you will start monitoring from 28 weeks, you will start monitoring the growth scan. So, what is the role of vitamin K in preventing hemorrhagic disease of the newborn and maternal hemorrhage in women with epilepsy taking anti-epileptic drugs? So, there are, now you have to remember these drugs, which are enzyme-inducing drugs. So, three drugs are the same, almost same. You can see here carbamazepine and oxcarbazepine and eslicarbazepine. These three drugs are having almost the same name. Okay, so these are the enzyme inducing drug, and then there are three P's: phenytoin, phenobarbital, and pyrimidone. These three P's, they are also enzyme inducing drugs, and topiramate. So if you remember the 3-3 rule, three drugs with the same name and three drugs with a P, and one drug is topiramate. So these are the enzyme dosage. Because why it is important? Because they will say the patient is, they will not tell you that this is a drug enzyme. They will say to you in the exam. Actually, this question come to me. The patient is taking topiramate. For example, the patient is taking carbamazepine, and now she asks you about contraception. So if I will know that topiramate is the enzyme inducing drug, it will be very easy for me to select the contraception for her, because then I will select for something reasonable for her. Okay, so that's why you need to remember by heart that which drug is enzyme inducing, because they will not tell you that they will just tell you that this she's taking topiramate or she's taking carbamazepine. So these are the most common drugs they are in the exam. Usually they are giving topiramate also sometime. So
Excuse me, Dr. Fauzia.
yes.
Can you tell Samia Faisal to close the camera, please?
What? What I
Samia
will.
Faisal, Samia Faisal, to
Ah,
close the camera.
okay. How I will mute
Just tell
everyone?
her.
Okay.
Just tell her. Tell the
Dr.
name.
Samia, can
So,
you close your mic, please?
no, not mic.
Huh?
Camera. Camera and mic.
Camera. Okay, okay. Just Dr. Samia, can you close your camera, please? Dr. Saima, yes. Dr. Saima, I think. Yes, Dr. Saima. You can close your camera. Okay. Okay. Yes. Before joining meeting, make sure you close your camera. I think I make setting, but I don't know. When I'm restarting, uh, I will see this issue. Okay. Okay, so we already discussed the enzyme-inducing anti-epileptic drugs. So these drugs, what is the mechanism of action? Because this exam they ask about the mechanism of action of tranexamic acid. So anything in the guideline, if written mechanism of action, please see what is the mechanism of action. So mechanism of action are considered to in competitively inhibit the precursor of clotting factors and affect the fetal microsomal enzymes that degrade the vitamin K. So basically, they affect the fetal enzyme. Okay, so fetal enzyme cannot inhibit the precursors of clotting factors. Okay. Okay, so what will happen? The fetus will be at risk of hemorrhagic disease of the newborn, because now their clotting factors, they are not using those clotting factors because of deficient enzyme. All babies born to women with epilepsy taking enzyme inducing anti-epileptic drugs should be offered 1 milligram of intramuscular vitamin K to prevent hemorrhagic disease of the newborn. I think all the babies they are giving vitamin K, but now specifically, okay, if they will give you, the patient have taking, you inform the pediatrician, and then what next? Then you will select 1 milligram of intramuscular vitamin K. That's it. So there is insufficient evidence to recommend routine maternal use of oral vitamin K for to prevent hemorrhagic disease of the newborn in women with epilepsy taking enzyme inducing. So routine oral vitamin K for the woman is not recommended. And also they said there is insufficient evidence to recommend giving vitamin K to women with epilepsy to prevent PPH. So either for baby or either for the mother, the vitamin K oral to the mother is not evidence based. So no studies have evaluated the effectiveness of antenatal administration of oral vitamin K in preventing PPH. So this is what the guideline is saying. What is the optimal timing and mode of delivery of women with epilepsy based on seizure control? The, majority of the women will have uncomplicated labor and the delivery. So diagnosis of epilepsy is not an indication for planned cesarean or induction of labor. Okay. So, in women with epilepsy with no underlying obstructive risk factors whose seizures are well controlled, there is no indication for early delivery also. So, if the patient have well controlled seizures, well controlled epilepsy, there is no indication of early delivery. And any medical disorder which is controlled before 40 weeks, we are not making delivery. We are not doing induction of labor unless there is additional risk factor of having post date with medical disorder. So if any, for example, even GDM, even epilepsy, even thyroid, hypothyroidism, asthma, all if are they are controlled, they are not indication for induction of labor. In a small proportion of women with significant deterioration of seizures, for example, they have recurrent seizures, they have prolonged seizures, or they are at high risk of status epilepticus, sometime we are doing elective cesarean section, sometime. But please see what is the indication of elective cesarean is women who are at high risk of status epilepticus, who have recurrent and prolonged seizures, or who have increasing frequencies of seizures. So these women, they might be for elective cesarean section. Even you don't want to induce them. Okay, you don't want to induce them, you just want to deliver by elective cesarean section. So how should women with non-epileptic attack disorder be counseled in pregnancy, and how should their non-epileptic seizure be managed? So they are saying that if you are thinking that this is non-epileptic disorder, you know you should not give anti-epileptic drug, and you know should not do iatrogenic early delivery unless you will have when there is a confirmed diagnosis of non-epileptic attack disorder. If you have confirmed diagnosis, then avoid to do early delivery and anti-epileptic administration. Okay, so because epilepsy and non-epileptic attack disorder, they have very different management strategies. um, Close liaison is required with the neurology and mental health team for further management where appropriate. So in these cases, non-epileptic attack disorder, you need to involve the neurologist, or you need to involve the mental health team. So they will decide that this patient need delivery or no. So where required, what dose of antenatal steroid should be given to women with epilepsy on enzyme-inducing anti-epileptic drugs. So enzyme-inducing epileptic drugs, doubling of antenatal steroid dose for prophylaxis against respiratory disorder in the newborn is not recommended. It's not recommended. Okay. So women taking enzyme-inducing anti-epileptic drugs such as phenytoin, phenobarbital, and carbamazepine may increase their metabolism of steroid with reduced therapeutic effectiveness. In routine, if the patient is taking enzyme inducing anti-epileptic drugs, we are not recommending the doubling the dose. They are saying maybe the phenytoin, carbamazepine, and phenobarbital, maybe they will increase metabolism of steroids, and but still there is no recommendation. This is written very clearly, so you will not double the dose. That's it. But keep in mind, maybe sometime case to case, maybe you want to increase the dose. I don't know because the guideline is not taking. So tomorrow I will read the talk article and I will see what exactly they are saying. Okay, sometimes talk article is more easy to understand because guidelines sometimes they are giving confusing studies. Okay, so I will see tomorrow and what is the answer I will see. Intrapartum care, what happened? Intrapartum care. Okay, I don't know what happened. I think there is some problem in our presentation. So I think so today class, because this class was in emergency. So the rest of the class I will take tomorrow and I will revise it. Okay. Shabnam Naz. I think I know Dr. Shabnam Naz. Okay. So today class I will take tomorrow and maybe I will want to revise it because I just prepared the class today and I don't know what happened. The half of this class, half of the guideline, it just disappear. Okay. So tomorrow, inshallah, I will take the class with remaining guideline with revision and with comparison with the talk article. Okay. So for until now, thank you for your time. Any questions? Please don't ask question today. I am not well prepared today. But anyhow, you can ask the question and I will answer you tomorrow. You have any questions?
No, thank you. Thank you.
Okay. Okay. Bye bye.